live.
Okay.
We can hear you.
So now, okay, we are into the junction D1, D2, and you have here the stent, the plastic stent. This is the bile duct. Here you have something which is tissue or sludge. Okay, this is the upper part of the duct. This is the lower part of the duct. This is the pancreas. Okay, and now we turn clockwise and we follow the stent and the duct till the region of the ampulla. Here you have the PD which is arriving here. Okay, here we have the duct, and now I push gently to study the lesion.
Can we have
And
the two
here
views,
you
endoscopy
here you
and
have the lesion.
EUS?
All that thing is the big lesion, you see? Okay?
As you guys can see, we're using MU3, the most advanced endosonography processor from Olympus.
Yes.
That's what we're getting pictures through.
And now I study this lesion.
Dr. Palazzo, can I ask a question,
Yes.
please?
Yes.
I always wonder about the ampulla, whether when I'm doing ampulectomy, is it long common channel? Is it PD alone and CPD alone? Does it make difference if I have long common channel or small when I do ampulectomy? Does that makes any? Do you study the length of the common channel?
Here you have you have no common channel. Look, this is the PD. You arrive, you push, you arrive here, and here you have the duodenal wall and the mass. The mass starts here.
Is it possible to show
So
us the
finally-
endoscopic view? The endoscopic view.
Sure.
Yes, we can, but after that we have air, but if you want. But you know, a EUS with air is not the best thing. So here you have the tumor, which is at that moment low-grade dysplasia. I will show you that it's not true with the EUS. So here you have the stent. Here you have this huge mass. Okay? And here you have the lower part.
Yeah, so it's around 3 centimeter, probably a polyp that showed adenoma.
Yeah.
Yeah. Okay, so now I will continue with AUS. It's here. So,
Dr. Palazzo, would you able
problem-
to assess ductal invasion with a stent inside, or you would prefer to remove the biliary stent first for assessment of ductal invasion?
You will see that in that case, of course, when it's small, it's not a good thing to have the stent. Because if you want to stage a small lesion with a previous sphincterotomy, and here you have a large node, which is not beautiful at all. You see this node? Okay? You see it? So when it's a small thing, if you have to do a sphincterotomy and the stent, it's finished. Finished for the diagnosis, finished for the staging, it's finished. You have to remove the stent, you do the biopsy, till the moment you have the lesion which appear on the histology. But do not ask to AUS to do the diagnosis of a small ampullary tumor, intra-ampullary tumor after endoscopic sphincterotomy and okay.
So,
So
Dr.
now,
Dr. Palazzo, I was
sorry, I will-
thinking about the size. The
Okay.
size is very scary here. And it looks,
so now
for me, it looks
now
more than 3 centimeters.
I will work, if you want, to show you the key of the exam, which is the staging. So first, we have seen that there are some malignant nodes, but I will show you other malignant nodes. You see here in front of the aorta and the vena cava, if someone can show. Yes. Here. No, here. Here, look, this node have nothing to do. Sorry, because I changed.
So if there is lymph node, there is no ampullectomy, right?
Okay, here you see this node are really suspicious. So we have lymph nodes all around the lesion, these are nodes of in front of vena cava and the aorta. And now we will stage the tumor itself. Sorry.
It's a tricky one.
Yeah, but
We were talking also, guys, before the case that this patient presented with painless jaundice, and that by itself really speaks against the benign nature of this lesion.
yes.
Yes.
Yes,
You have to be very, very careful.
If you have jaundice, which is not cholangitis, but jaundice.
Not
If you have-
sludge or stones. Yeah.
If you have jaundice in ampullary lesion, we have the figures. 94% are adenocarcinoma. If you have a cholangitis, it's not the same thing. Any ampullary tumor can give cholangitis, and it does not mean that it's a cancer. But when you have a real jaundice, so here, look, this is the staging. Can you show them the involvement of the muscle?
So, okay, guys, if you can see, this is the duodenal wall. You can see the folds, the duodenal folds here. And we can see the tumor here, mostly intraluminal. And then over here, this is the MP layer. This is what we really focus on here. And this is the pancreas here to the right. We can see the lesion here. You can clearly see the
The
tumor, the
lesion
hypofluid.
is entering the muscle. You see here? Okay. So here we have the staging of this benign lesion, which is in fact an adenocarcinoma, at least T2. You see here? Okay. So this is the goal of EUS when you have low-grade dysplasia. When you have low-grade dysplasia, the question is a real low-grade dysplasia or a false low-grade dysplasia? Here it's a false.
So you think that is based on the EUS that there is a submucosal invasion, is that right?
Yes, and
Yeah.
the muscle
And
invasion.
the muscle.
Yeah.
Muscle.
So you
Yes.
can see here, you can see the muscle
No.
layer nicely. You can see
This
it
is the
intact.
black line, and here you see the black line is interrupt. Okay? Interrupt.
Okay, so the muscular
Okay.
layer is
So, and-
interrupted.
And yes, and you have other signs when you look at other area. For example, the submucosa on the duodenal wall is also passed, and the lesion move from the the inside of the ampulla, moving through the submucosa to the inner layers, which means that also on the lumen size, the depth of the lesion is malignant also here. Okay,
Right.
so okay, so the problem is that you have a benign lesion on biopsy. When you look at it endoscopically, you do not find real signs
Needle,
of
that's
malignancy
22 gauge needle.
endoscopically, but the
Microscope.
patient has jaundice, real jaundice, so you know that 94% will be adenocarcinoma, and you want to be sure that it's an adenocarcinoma. What do? You do an EUS, and you find this involvement of the muscle. It's finished, you know it's malignant.
What about distant lymph nodes?
Yes.
So our next move
And,
will be.
and you can biopsy the node or biopsy the tumor.
So, doctor, will
So
take
the next
direct
step for us
biopsies
will
or
be
fine
to
needle
get a
biopsies?
fine needle biopsy of this. We're going to use the Trident Microtech needle, 22 gauge, of either the primary tumor or one of those lymph nodes. And I think any preference for you?
Or usually I do both, but
Okay, well,
Yeah,
that's a
so-
good preference.
So Dr. Palazzo,
Perfect. Thank you.
what about
Yeah.
bile duct involvement? I think you can still tell